Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, probably the last podcast for 2025, I'm going to be doing part 3 of the opioid series. Part 1 was with a harm reduction specialist. Part 2 was about nitazines and the opioid chain of survival. Those were both we's. This one's a podcast because this fits the purpose of EMCrit to a T. This is medetomidine overdose and withdrawal. And this is clearly a resuscitative issue. It clearly is an intensive care issue. Many of these medetomidine withdrawal patients wind up in the ICU. They could be really, really sick. And in Philly, it took up, at any given time, between 1/5 and 1/3 of their ICU beds. And I am sure this will be coming to an ICU and ED near you. So you got to know this stuff, hence why it is a podcast. I am joined by a guest toxicologist, addiction medicine specialist, Jean-Marie Perrone. You will hear her introduced in a moment or two. We're essentially going to be talking about 2 drugs that are adulterants to the opioid supply. We'll briefly talk about xylazine, which is a alpha-2 agonist with spillover to alpha-1. It was prevalent in Philly for a while. It was causing these horrible wound complications, but it's almost completely gone. Now it has been superseded by medetomidine. So that's what the lion's share of this discussion will be on. And we'll talk about medetomidine overdose and how that looks different than opioid overdose, as well as medetomidine withdrawal, which is a pretty brutal syndrome that patients get super sick from. So what are these drugs? I mentioned xylazine, alpha-2 agonist with spillover to alpha-1. It's non-selective. And then medetomidine might seem new and novel. It's actually not, because it's essentially just dexmedetomidine. And so the thing is, medetomidine is the racemic mixture of dexmedetomidine and levomedetomidine. Dexmedetomidine just refers to the right-sided enantiomer, and levo is the left-sided. So the levomedetomidine is inactive, essentially. So medetomidine is just dexmedetomidine with a little bit less potency because it has that inactive enantiomer mixed with it. But in the doses that are being put in the adulterated opioid supply, you get a significant dexmedetomidine-like effect. And then, since these patients are on it for weeks or months, you could get a significant syndrome very similar to dexmedetomidine withdrawal. So that's essentially what we're dealing with. So we will get into it momentarily. Just a real quick plug for some of the stuff outside of the EMCrit podcast world. I will mention the dizziness course I did with Peter Johns, some of the best education we put out in the past few years. You should totally check that out at vertigocourse.com. And then the Awake and Aware conference that we're doing in Scottsdale in March is going to be absolutely incredible. It's going to create a retreat bubble. It's going to be a small group of like-minded souls searching for joy and productivity and happiness and equanimity, doing that with some of my other coaching buddies that you'll know, most of them. And it's just going to be amazing. We're going to eat meals together. We're just going to try to create this little bubble of joy. If you're interested in that, go to wakeawareconference.com, or I created a new page that I put all of the stuff going on with EMCrit on, and it's emcrit.org/stuff. emcrit.org/stuff. STUFF. So just go there at any time and you'll find all the stuff going on in the EMCrit universe. All right, let's roll right into the show on medetomidine overdose and withdrawal. Why don't we start where we always do? So who are you and what are you?
So I am Jean-Marie Perrone. I'm an emergency medicine physician. I trained in medical toxicology in Bellevue, NYU, working with some of the greats in toxicology, and then took my first and only position at the University of Pennsylvania in the emergency department, and gradually shifted from toxicology to safe opioid prescribing, and then transitioned to picking up the pieces of the addiction crisis. So now I run the Center for Addiction Medicine and Policy at the University of Pennsylvania, and I work in the ED, optimizing ED addiction care access, and run a lot of addiction programs for the health system.
Yeah, and it's pertinent that you're in Philadelphia because it's the prelude to what the rest of the country gets to see in terms of opioids. So you're right in the epicenter of the adulterants of our opioid supply on the streets. And I guess we should start with what is, in essence, the first adulterant that really had prominence, which is fentanyl. So is there still regular heroin out on the streets in Philadelphia, or is it all fentanyl at this point?
I think you could generalize and say it is all fentanyl. We do here and there have drug screening that shows a little bit of heroin along with fentanyl. And sometimes people's urine drug screens may show a little oxycodone, a little heroin, a little fentanyl. But the majority of the driver of opioid challenges, I think, comes originally from fentanyl in the past 3 years, and then obviously some of the newer adulterants as well.
Absolutely. Now, fentanyl, while it may lead to greater overdoses just because of its potency, from the EM perspective, we pretty much know how to deal with it. Naloxone still works.
And I do often get asked, does naloxone work? Do you need higher doses for fentanyl? And I think we know from our experience that you don't need higher doses, but you do in this mixed overdose syndrome. That's where we're really seeing people doubting whether or not naloxone works. And it's really not that naloxone doesn't work. It's that there's other adulterants and other reasons why people are persistently sedated. And I think that's a really important lesson. We don't need higher dose naloxone. We don't need all these other drugs coming to market. We really just need judicious use of naloxone and critical care support for people who are maybe still somnolent, but breathing better.
I came from a Lou Goldfrank type training where we were giving very small doses of naloxone. We were diluting our 0.4 by 10 and giving 1 cc at a time of 0.04 just to effect. Is that the way you guys are practicing in Philly as well?
It is. And I think that you can be fooled with 0.04 if you stay so low. You really do have to go up to 0.08, 0.12 to see an effect. So stopping at 1 dose or 2 doses when it's that dilute, it can be a mistake. But we do see an effect, and we do generally recommend starting super low. EMS does use 0.4 IV, but they also use intranasal. And intranasal is a whole nother category of challenges, because if you've ever actually given intranasal naloxone, you have to be quite up close to a patient who you probably don't was laying on the street. So we know that levels and concentrations of naloxone given by bystanders is lower than concentrations given by EMS. And even EMS can get it wrong. We can all get it wrong, but it's not the same as IV naloxone.
So we adapted to fentanyl as an adulterant, but now we have these new class of veterinary anesthetic drugs. And I guess the first one to hit Philly was xylazine. Tell me a little bit about that.
Yeah, so xylazine, I think in retrospect, we have a clearer understanding of its potency as an alpha-2 agonist in terms of causing a withdrawal syndrome. Xylazine, patients who use drugs had a lot of complaints about xylazine, notwithstanding all the wound issues that we think are associated with xylazine. But people said it made them restless and irritable and anxious. And those symptoms we really attribute to early opioid withdrawal. So patients said the withdrawal was worse, but what we saw objectively was just people who could be pretty well treated with full opioid agonists and wouldn't have, that ongoing restlessness and anxiety and dysphoria. However, now that we're seeing medetomidine withdrawal, we are seeing a much compounded version of those same symptoms, along with all the autonomic symptoms that I'm going to talk about. But I do think that there is a pretty distinct alpha-2 agonist withdrawal syndrome now that medetomidine is an example of, but in retrospect, we were probably seeing some hints of it. We never saw the vital sign abnormalities with xylazine, maybe a little more bradycardia in an opioid overdose that involves xylazine, but the people weren't really getting any sicker per se, but part of that is clearer now that we're seeing a much, much more advanced withdrawal syndrome.
Yeah, let's stick with xylazine just for a sec, and then we're going to go to the obviously more predominant medetomidine. So the xylazine wound issues, was this primarily or entirely from vasoconstriction? And did patients just get wounds that they would get in the course of everyday life become much worse, or were they having de novo wounds started as a result of the xylazine?
Those are all great questions, and I think all of them are kind of the right answers. We initially thought that xylazine came out at the same time as fentanyl or shortly thereafter. So people were injecting more times per day because fentanyl was shorter acting than heroin. So there were more skin breakdown, more introduction of bacteria, et cetera. People also started using methamphetamine, so there was more excoriations and scratching. So for a while, many of us really thought this is just a coalescence of a lot of things happening together. And then, of course, the housing crisis compounding it, people with poor access to water and ability to make a small wound heal that grew into a bigger wound because of poor wound care. So the temporal relationship to xylazine and wounds is definitely clear. In terms of pathophysiology and vasoconstriction has been propagated as a possible etiology. Patients didn't get the wounds necessarily where they were injecting. So you'd often see people, just like other unhoused people, with wounds on their legs, but not where they were injecting. It's hard to explain vasoconstriction in sites where they weren't directly introducing drug. Very often they would be at sites where they do inject. What happened also was that even like in the legs and other places that were distal from injection sites, they would start to inject there because of pain. So then everything got a lot worse. People would have multiple small ulcers that would coalesce into bigger, poorly healing large wounds that became larger, and amputations, and a lot of really horrific challenges associated with that.
Yeah, we thought xylazine was bad, and then medetomidine came around and taught us a lesson on be careful what you wish for. Before we go into that, do you have any supposition about why they're adulterating with these veterinary anesthetics? The fentanyl was obvious. All of a sudden, you don't need a poppy field. You could just, in a tiny lab without very much high-level chemistry education, create enormous amounts of this. So that made complete sense. I was baffled as to why they were cutting with this. And then I was speaking to a harm reduction technician, and she posited two things, and I wonder how they hit you. One is that our crackdown on fentanyl was actually one of the reasons that this adulteration was happening. You run out of the easy availability of fentanyl and you want to start cutting with something else. The other one was that this kind of locks people into a supplier, because if they go to somewhere else, they've been on or xylazine for a while, and then try to switch to a different dealer who's coming from a different supplier that does not have this adulteration, then their withdrawal syndromes are not going to be fixed by just a fentanyl product. Did either of these two resonate? Do you have other suppositions as to why? What do you think, Jean Marie?
There's always been cutting agents, adulterants in the drug supply. I think what makes the most sense, specifically starting with xylazine, is that it was a cheap, psychoactive, non-controlled substance that could add sedation without adding to the incredibly potent respiratory depressant effects of fentanyl. So for me, that's a satisfactory explanation of xylazine. There was some historical roots of its being exposed in Puerto Rico. And I think people who do drug supply work really study history and chemistry and have a long list of what could be added next, in at least my experience and what I'm guessing at. I think the shift from xylazine to medetomidine is possibly related to, in Pennsylvania, which, as you said, seems to be the ground zero of Philadelphia, we scheduled xylazine. There was a lot of debate in the FDA whether or not you could schedule a veterinary drug that wasn't. Controlled substances are supposed to be for human consumption, controlling the supply in people, but every state could put their own jurisdiction around it. So Pennsylvania actually did schedule xylazine as a controlled substance very shortly before all of the emergence of medetomidine. So I think the way it's been explained to me from the DEA is that when a case of xylazine falls off a truck, there's no accountability for that. When it's scheduled, there's a lot of dots and T's and I's that need to be checked. That's our reasoning. And as much as Philadelphia has led the way, it usually sort of radiates out from Philadelphia to New Jersey and Delaware and New York. This time we saw a huge bolus in Pittsburgh. So this is the first time Philadelphia and Pittsburgh have had such a similar drug supply. For those of you geographically less aware of Pennsylvania, we are about 6 hours apart. So those are not proximal cities.
All right, let's get into medetomidine. This was pain in the butt in two ways. One is the actual OD that would show up in the emergency department, and then we'll talk about the horrible withdrawal issues. So why don't we talk about the presentation first? How does a patient who has an adulterated opioid supply with medetomidine appear differently than your typical opioid user? So why don't we talk about that first, Jean Marie? So patients come in and they might have even got an EMS naloxone intranasally, and they're still quite sedated. So how did these patients look when you first started seeing them?
It was even unique that we would see patients brought in by EMS, because traditionally patients who had a fentanyl overdose and got naloxone tend to refuse transport. So we start seeing this increase in the need to transport patients, which sort of preceded the clusters of overdoses. But there were more patients who were not responding to just naloxone. And I would say that maybe the hallmark of those early overdoses were bradycardia with maybe a little bit of hypotension. They didn't tend to need pressors. They responded to fluids. Their respiratory, generally, I think in the case series reported by Temple Hospital, 1 in 11 of them got intubated, they tended to have sufficient respiratory support with just naloxone reversal. And then they would just be sleepy with some abnormal vital signs, and tended to be bradycardia that was hemodynamically insignificant. And I would say this probably looks the most like clonidine overdoses in the era of clonidine being either missold as Klonopin or sold as a drug that could mitigate opioid withdrawal. Those patients were very deeply sedated, but if you really stimulated them, they'd wake up for a second, they'd talk to you for a second, they'd go back to sleep, much like kids who have a clonidine overdose. And then they would have a sinus bradycardia, generally not associated with hypotension. So I'd say that's what it looked like the most.
So how long, we're used to 3-4 hours booting our opioid overdoses. How long would you keep these? And how would you determine, did these patients need to be admitted, or would you just keep them in the ED?
In the beginning, I think that's a very clinical threshold risk strategy. Are you going to be able to watch the patient throughout your shift, and then you're sure they're going to be able to go home?
Hey folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
So I think a lot of that is really a bedside call. They tended to be hemodynamically stable but somnolent. Depending on how much of the drug they got, they might have been there for 4 to 10 hours. And maybe some were still sleepy and got put in observation. I know the one got intubated in the Temple series because of persistent sedation.
All right.
But I would say that in general, those patients were, similar to any overdose that you were going to just kind of let sleep off with stable vital signs.
Now, overdose may be a little bit annoying, but the medetomidine withdrawal is where the real pain exists. So let's talk a little bit about medetomidine withdrawal.
So, starting with the withdrawal phenomena, what we tend to have seen is patients coming in, and this is in the beginning. So it's almost about a year. September, October last year is when we began to see these patients coming in. And they would first we heard it on the street from a lot of our peers and navigators, like the withdrawal's been really bad lately. People are saying that they're getting really sick faster. So then that makes us think that there's more fentanyl in the supply or the fentanyl dependence has changed. But then when we started seeing patients, they would just come in and say, I've been feeling so bad, things are worse. We would give them what we normally give them, which is they were seeking treatment. So we'd either start them on buprenorphine or more generally in our area, methadone. So they'd get 40 milligrams of methadone, they'd be comfortable for a little bit. And the one case that several of us have talked about was just this young woman who presented with this normal vital signs, got some methadone, was fine, was waiting to be transferred to an intake place. And then her symptoms started to escalate. And she said, this is what it looks like. I feel really sick. And she has this kind of tremor that's not really coarse, but a tremor, a diffuse body tremor, nausea and vomiting that becomes very difficult to control. And then these tachycardia, diaphoresis, pupil dilation, and hypertension. So those are the parts of this that you may want to reach for clonidine, and that's what we generally do. But the clonidine is only available orally or by patch, which is a little too slow. And then these patients get so much vomiting that the clonidine component, they can't keep it down.
With the prevalence of it in Philly, it's got to be a real pain in the butt. How many of these patients were taking up beds in your ED? Was it a real issue?
We didn't see as much of the cluster of overdoses. We saw a smattering. What's really interesting is how we all had to work together. We have 3 or 4 large academic health systems in Philadelphia. This has really brought the frontline emergency physicians, addiction physicians together to really talk about this. Because if you saw the syndrome, as I described it, hypertension, tachycardia, nausea, vomiting, patient saying withdrawal is, okay, this is probably benzo withdrawal, and you don't know that there's benzos in your opioids, or this is alcohol withdrawal, and you're not telling me that you use alcohol. Although both of those things might be less common to begin with, when we saw lots of them, and then Jefferson was seeing lots of them, and Temple was seeing lots of them. And really kudos to the health department who put all of our little siloed pieces of information together and said, let's meet and talk about this. And that's when we started looking at what was new in the drug supply and how we could attribute it to something. Because there were lots of things on the table. There were new local anesthetics. There was this drug BTMPS that had been newly detected. And we were looking for the link between, what is the new adulterant and how could it account for these symptoms?
Yeah. So you had gone into a more mild withdrawal that you might treat with Clonidine in the ED, but I know you folks had a bunch of patients who needed ICU level care. What was the break point to say, we're going to have to keep this patient in the hospital and we're going to have to potentially put them in a monitored setting? Tell me about those really sick withdrawal patients.
Well, a lot of the withdrawal patients are really sick, and they're different than the overdose patients. So these patients the overdose patients primarily would be discharged. Maybe there was a small handful that got sick while they were waiting in the emergency department, while they were sobering up and then shifted quickly into withdrawal, but less, and especially because most of the overdoses we saw in the beginning were when people hadn't had weeks and months of exposure. It takes a while of using this drug before you're going to have an abstinence syndrome. So the patients who were coming in the beginning with this withdrawal syndrome, we didn't really know to push the clonidine that we are trying to do now to avoid it. The patient might be the most prominent symptom is elevated blood pressure, elevated heart rate in the setting of vomiting. Now, that doesn't look that different to me than cannabinoid hyperemesis syndrome, right? Those patients have terribly high blood pressure. They look miserable. They're vomiting incessantly. And we don't jump to manage their vital signs. We jump to manage their vomiting. So that's what we were doing. And every antiemetic, I think we're probably the most skilled at antiemesis clinicians. There wasn't a combination that would really come up with success. Patients still vomiting, you have to use IV meds for everything. And then in order to get patients to the floor or somewhere, that blood pressure needs to be managed. We were trying different blood pressure management strategies, but when it all came together, and we were trying benzodiazepines too. Again, we're thinking part of this might have been benzo withdrawal and might help with the emesis anyway, but just really couldn't get that under control. And then for the patients that ended up in the ICU because of elevated blood pressure, they were getting dexmedetomidine to concomitantly add to that. And maybe there was at some point an observation on our part around the same time that we discovered that maybe this is most compatible with something that looks like a dexmedetomidine withdrawal syndrome. You probably have more experience with that than I do, but from the few published case series, that's when we came together to say this might be similar to dexmedetomidine withdrawal or something that we can attribute to this medetomidine exposure.
No, I think it was a beautiful elucidation of all of that stuff that was done in the Philly area to really figure this out. So it's super cool, and the rest of the country could learn from it. This drug is far more potent than dexmedetomidine. It has a more potent withdrawal syndrome. There is a veterinary drug that I'm sure you're familiar with. What is it? Pamazole? Or I'm sure there's a different enunciation that I should be using. But do you think that's going to come on the scene as this becomes more prevalent across the nation?
Another question I get frequently asked, and I'm glad you asked it because it's important. I think as emergency physicians, we think of what we can manage in the emergency department. And between naloxone and critical care, we can manage people who are persistently sleepy. We can put them on naloxone infusions. We've had a long history of having flumazenil available, but we don't want to use it for a benzodiazepine intoxication because of the risk of withdrawal. So it's a very comparable analogy there. Is there a role for it on the street? Is there a role for a long-acting version of it or something that might prevent people from getting exposed? That's probably outside of my wheelhouse in terms of pharmacology, but might be some things that people are considering. But as a strict reversal agent, I would say there's not a role right now.
In terms of a customer-based opioid adulterant, this one seems pretty bad for the customers. I don't think they're happy with this, having to spend a week in the ICU and not be able to get their normal fix and do all the things they want with the rest of their life. Do you think this is going to disappear as the realization of the dealers and probably the upstream, the suppliers, that this is not the ideal choice? It didn't work out as well as they thought. Do you think it's going to fade before it spreads, or do you think that this is the future for most of the country? I know I'm asking you to project here into the
I think there's a lot of researchers out there that want to know, should I invest my PhD thesis in this or not? Xylazine also had a lot of adverse effects that you would think would drive people away from it. I don't know. In Philadelphia, all I can say is people don't have a lot of choice. We've had very high concentrations of xylazine. Now we have high concentrations of medetomidine, high prevalence. In places like anywhere outside of here, the role of test strips could really make a difference, could influence the market. But here, people are very honest and say, if it tests positive for xylazine, I'm not going to throw it away because there's nowhere else I don't have another option. So in that way, I'd say xylazine hasn't disappeared other than medetomidine displacing it. So I think there's still going to be a role. If we schedule medetomidine, what's next? There is another veterinary drug that we haven't seen yet called, I think, Demetomidine. That's not dexmedetomidine, but another alpha-2 agonist. Maybe that's going to emerge. I don't know if that's worse or not as bad as medetomidine.
All right. The last question I had, and then I'm curious to see if I missed anything from your perspective, is would, from a harm reduction perspective, it just be better if we had, just like we have cannabis shops everywhere, we had opioid shops? And yeah, there's going to be some downside to that. People who may have been naive and never tried in their life may actually try it and then get addicted. But yet it doesn't seem like what we're doing right now is working. And the prohibition with alcohol, I think, was a lesson that people are going to find a way. And the way they're finding right now is a very unmoderated, unsafe supply, when we could probably do better. What is your stance on that social libertarian experiment of legalizing opioids?
I think we're really far from being able to manage that safely. I don't think the cannabis experiment has been great for our youth or our urban population. So I can't imagine the opioid experiment going very well. What happens with opioids, that maybe doesn't happen with cannabis, is this escalating dependence. So when will safe supply ever be enough? You just see people getting more and more dependent in a way. I've seen it therapeutically in incredibly high doses of people who were treated with crazy doses of pain medication. We know some people in Philadelphia use 40 bags a day. So that really adds to what would safe supply look like. We do have methadone, which is essentially a safe supply concept. It is not very customer friendly and obviously going somewhere every day. But some people really need that structure. Some people do really well on methadone. I wish that buprenorphine didn't have some of the hiccups that it's had in the setting of fentanyl, because I think we do have a great treatment that doesn't require as much of the restrictions methadone does. But yeah, I would not be in favor of that. I don't think it could work in our society.
All right, what I missed, Jean Marie? What should I have asked you?
I guess we are clonidine as an early treatment before the vomiting starts. If you have somebody who's recently been hospitalized, say, that would be the easiest patient to know that they're at risk again. Recently hospitalized in an ICU for medetomidine withdrawal. I think that I would start with very high doses, assuming their blood pressure is reasonable, but starting with 0.2 or 0.3 of clonidine Q4 or Q6 hours, depending on what the trajectory is. We do use a lot of full opioid agonists to also manage opioid withdrawal. Getting the vomiting under control is really important. So if you can tag team the full agonist opioids plus the clonidine, and then being able to get enough standing dose clonidine into people, then we've seen a small decrease in the number of patients who go to the ICU by catching it early. The other thing is it's hard. Not everyone with the treatment of withdrawal is patients with alcohol withdrawal come to the hospital and develop withdrawal while they're trying to get treatment for their alcohol or for something else. So right now we are still admitting a lot of people just for opioid withdrawal, but we're trying to connect the dots of, do you want treatment? Because what's going to happen when you go back out? We aren't able to protect you from this happening again. So hopefully we can use it as a segue to, aren't you tired of this? You're going to be back in the ICU again if we don't do something differently. So we do have lots of treatment connections, but they are not always being able to convince the patient that this is the time. Hopefully, since we're seeing more patients in the hospital setting, we are connecting the dots to longer acting treatment, methadone, buprenorphine, Sublocade.
Let's say you had a patient who you thought was medetomidine withdrawal, and it's mild at this point, and you gave them some clonidine, and you talked to them, and they're like, look, I don't want to come into the hospital. I'm going to go out and get another bag, and supply almost certainly is going to have medetomidine in it. Would that be a patient you could just discharge if they stabilized with clonidine?
I think you can make sure they have Narcan and the phone number for your hopefully low barrier treatment setting and say, we are here. We really want to be supported, connect them to a peer if possible. But I think those are patients that we shouldn't convince that they need to stay in the hospital if they're not ready for treatment. I think their kind of exposures on the outside are still going to be not going to lead them more dangerously. We can't put everyone in the hospital.
Yep.
So I think that's okay.
Just for my own curiosity, how long do these patients wind up staying in the ICU if they have withdrawal severe enough to make it there?
It's been like 48 to 72 hours. I mean, I would say like a third of something between 20 and 30% of our ICUs are filled with patients with medetomidine withdrawal. So it is a challenge on utilization and other capacity in the health systems.
So we've spoken a bunch about the ED management of medetomidine withdrawal, but a lot of these patients wind up in the ICU. So I want to just briefly mention the ICU treatment of these patients. And this also comes from Jean Marie's site, which is pencamp.org, and it's linked in the show notes. And they have a document, which I've also linked, on the ICU management of opioid withdrawal with adulterants, with the assumption being that it's medetomidine. So here it is. But again, read the document. It's really good. This is like the key paper you're looking for that has all of the practical knowledge on how to handle these patients if one of them winds up in your ICU. So you're going to put them on both long-acting and short-acting opioids. The long-acting is going to be methadone unless there's a contraindication. Even if the patient eventually is going to be on BOOP for their long-term opioid use disorder management, methadone is the drug of choice here. Monitor the QTC, and if it's prolonged, then maybe you go with a different option. And short-acting opioid regimens that can be titrated, which if they could tolerate oral, is going to be oxycodone, and the doses are in the paper, or if they can't, hydromorphone. All right, then you can put them on dexmedetomidine at the beginning. If they're sick enough to need the ICU, they're probably going to need a titratable IV medication. And so they give the starting doses starting at 0.5 micrograms per kilogram per hour and titrating up. You could stop by nursing titration protocol at 1.5, but docs may want to go up to 2.5 if necessary. If these patients are really in extremis and really in bad shape, you might want to give a 0.5 to 1 microgram per kilogram bolus if the patient's super sick. But again, always be worried by the possibility of hemodynamic compromise with dexmedetomidine bolusing. Ketamine is a good adjunctive drug. The dosing and rationale is discussed in the document. Olanzapine or prochlorperazine for nausea. And if the dexmedetomidine is not enough for the patient's profound hypertension, then antihypertensive agents like nicardipine or esmolol could be used. And then as the patient starts weaning and getting better, you start weaning down the dexmedetomidine, you could transition them to a clonidine PO or patch. All right, but again, check out their ICU document for the full management. I can't thank you enough. I've definitely been educated in the course of this conversation. Even before this, I read your papers. Is there anything else you'd want me to put in the show notes that you think is pertinent or helpful to people?
Yeah, we have a bunch of the webinars that we've done and the papers that we've written on our website, Penn Center for Addiction Medicine and Policy, pencamp.org. If you put a link to our website, you can find all that stuff there. And happy to chat with anyone who has other thoughts about this. I think it's really an evolving syndrome, which is one of the most interesting parts about medicine and toxicology, but really a formidable challenge for clinicians and patients at this point.
Again, can't thank you enough. This has been fantastic.
Thanks. Appreciate it.